And smokers are more prone for perforation. There's ulcers are more prone for perforation. Smokers. So again, there are certain dietary the food substances which can cause your acid peptic diseases. But what exactly the mechanism is still not known. There are certain foods and beverages. If you are allergic to that particular thing, usually they say spicy. But again, this is controversial. The spicy food may cause symptoms, but may not really cause the uh, ulceration. There are a lot of studies were done, but yes, food is one of the reasons in some people, food and certain beverages. So, what are the signs and symptoms of these ulcer-related disorders? What are the signs? As you know, it is only pain, pain and pain, upper abdomen pain, or they can come with first time they can come with bleeding. If it, especially if it is a gastric ulcer, it sometimes many times gastric ulcer patients will not have any symptoms. They may first presentation could be just the perforation or massive hematemesis. They can come first time with that. They may not have symptoms for a long time, and they also can come with obstructive symptoms. If there is a duodenal ulcer, if it is a chronic duodenal ulcer, while healing, it causes a narrowing of the Arvaz, can you show here? Especially the pylorus, the pyloric end of the stomach, the pyloric end of the stomach gets narrowed and you get what is called as a pyloric stenosis. If patients come with obstruction, stenosis, recurrent vomiting, gastric dilatation, you do an endoscopy, you find the pyloric stenosis, obstruction of the gastric outlet. It's called gastric outlet obstruction syndrome. So in these patients, usually they don't respond to the oral medication. You have to submit the patient for surgical repair. So, so as I said, the pain is not very typical. It can mimic any pain. Usually, it is a dull aching. Sometimes they may have burning sensation. Usually in the epigastrium, mid upper abdomen, or sometimes if it is a duodenal, it may. If it is occurring posteriorly, posterior ulcers, patient may come with interscapular pain or even right hypochondriac pain, mimicking cholecystitis and other pancreatitis and other things. So the hallmark is definitely pain, but the location is variable. It's an ill-defined, aching, dull, boring pain, and some they can come with heartburns, burning in mid-chest pain, acid reflux pain, and that. And this pain looks just like hunger pain. That's why when you eat food after this pain, you feel kind of relief. Okay. Typically, the duodenal ulcer patients will have pain after 1.5 to 3 hours of food intake. Typically, after 1.5 to 3 hours of the pain. Unlike the gastric. So it's a gastric ulcer. The moment you take food, the pain increases. And this pain, the duodenal ulcer pain, decreases with food and decreases with antacids. And somebody has a severe pain in the middle of the night, so you're waking up with the pain around 12 o'clock midnight to 3 or 4 o'clock in the morning. That is again a typical duodenal ulcer pain. And 2/3 of the patients will have some kind of nocturnal pain if they are suffering from duodenal ulcer. Coming to gastric ulcer, it is the pain is precipitated by food. The moment you take food, you get pain within 15 to 20 minutes. That is one of the uh, uh, important timing of the meal timing. What is the mechanism? Till now, so many investigations we have done, so many research have gone into. But what is the exact mechanism of the pain of the duodenal ulcer or gastric ulcer is not very clearly understood. So on exam is signs. What is the clinical picture? Signs and symptoms. Signs and symptoms, clinical, we have epigastric tenderness, but generally all our junior doctors, residents and PGs, we have a bad habit of writing acute gastritis for any tenderness, epigastric tenderness or patient coming with vomiting. So mind you, You are allowed to write gastritis only when there is a histological evidence of inflammation. So gastritis is not a, it is a loosely used term. Every day we see our doctors writing acute gastritis. Any upper abdominal pain with vomiting, acute gastritis. So gastritis should be used, the word should be limitedly used only to the histopathologically proven gastric inflammation. Otherwise, if until then, you have to call it as a dyspepsia. This is dyspepsia. Not every patient coming with upper abdominal pain and vomiting is acute gastritis. We loosely use this term. Many doctors. So be careful when you are writing that. Dyspepsia is the right diagnosis. You investigate. If you do endoscopy and then see if there is inflammation, if there is a biopsy-proven inflammation, then yes, it is gastritis. Gastritis is not as common as we think. Again, if the patient is in a bad shape, suppose patient has bled or perforated, they can come with tachycardia, dyspnea, and hypotension. Hypotension if there is a bleeding or hematemesis, massive blood vomiting. If the patient has perforation, he can come, but the patient can come with acute abdomen-like picture, board-like rigidity, and which you have to immediately submit the patient for proper investigation. And if you take an X-ray chest, you can see the gas escaping from the perforation under the liver. So you can nicely see even simple plain X-ray, erect abdomen. Patient should be made to stand if possible. The standing erect abdomen X-ray, you see some gas escaping into the under the liver. That's the most common evidence of a perforation of the hollow viscous. It could be gastric or duodenal ulcers. So these kind of patients have to be submitted for emergency surgical repair, laparotomy. And sometimes when there is an obstruction, as I told you, when there is an obstruction to the pyloric end, gastric outlet obstruction syndrome, the patient will come with bloating of the abdomen, fullness of the abdomen, because the gastric emptying time is delayed. A patient will have no appetite. The patient will not feel like eating. And if you put a stethoscope on the abdomen and shake the patient, you can hear that sounds. It's something like suction splash that you get in the respiratory system examination when you are dealing with hydropneumothorax. So excess quantity of fluid present in the stomach because of the pyloric obstruction, you can literally, if you put the stethoscope there and just vigorously shake the patient, you can hear that fluid sound in your ear. That is one indirect evidence of suction splash is indirect evidence of pyloric stenosis, gastric outlet obstruction. Yeah. What are the differential diagnoses? Somebody is coming with epigastric pain, is a smoker, he takes non-steroidal anti-inflammatory drugs. All these patients need not be having this ulcer-related diseases. So what are the differential diagnoses? Differential diagnosis is like functional dyspepsia. What is a functional dyspepsia is another chapter, another topic. What is a functional dyspepsia? Functional dyspepsia, patient has similar features of ulcer, but there is no ulcer. Endoscopically, if you do an endoscopy, there is no ulcer. Just some erythema will be there in the stomach mucosa. But this is called as a functional dyspepsia. Most of the patients that we diagnose as acute gastritis are in fact having functional dyspepsia.